All right. So, um, anesthesia is what they're wanting to do is differentiate it from general anesthesia. When you go to the hospital and have an operation, they put you all completely under. So, local anesthesia is the loss of sensation in a circumscribed area, which means it's just within a boundary. It just gets a little bit, it doesn't go all over. The anesthetic does go to every part of the body and your organs, but it doesn't, it's not anesthetizing or numbing that the whole way, everything that it touches. So, local, it's just a local loss of sensation within a boundary, and that's deadened, but you're still awake. Okay, so Carl Kohler was the first to isolate and use cocaine as an anesthetic, and he used it in the inferior alveolar injection. I would know that. Okay, so a long time ago, the methods of inducing, and the reason I'm going over this is because I've seen review questions in the book about different, like just one ever, but I've seen a couple different books that they'll have at least one about this methods of how they used to induce local anesthesia. So they would smack each other on the head or mallets or put pressure on their blood vessels, try to kind of make putting pressure on it, hoping that whatever they were doing on one side or the other of that pressure was not causing any pain. They would numb things, parts of the body with ice, hoping that that would freeze and they wouldn't feel anything. They try to make each other faint by just having no air at all. So hopefully, while they were fainted, that they could do these um, procedures. So they had chemical irritants, which is what chemical, it's not an irritant, but an agent. A chemical agent is what our local anesthetics are. They're chemical agents, but Benadryl affects the transmission of nerve impulses. That's how it works. It's a chemical actual irritant to the body. Ethyl chloride spray is an irritant. It's refrigerant for minor sports injuries or injections, etc. Then they had neurolytic agents with their ethyl alcohol injections back in the 20s. They for severe pain, but they had a really short life expectancy. And neurolytic agents are now used for neuropathy cases. And neuropathy cases, for those of you who don't know, are when like it's a feeling of when your leg goes to sleep or something and it's waking back up, that tingling, annoying feeling that you feel. And some people feel that all the time in their feet or their hands or whatever. And so neuro is nerves, of course. And they feel that tingling all the time and they're wanting to have something to stop that. And over the counter and sometimes prescription, they will make a capsaicin cream, or over the counter, you can definitely buy a lidocaine patch. Lidocaine is one of our anesthetics, that real anesthetics. So there's a variety of them now at drugstores and that you can get for prescription. But the best method is the chemical agents, which are our local anesthetics. So the chemical barrier, local anesthetics are deposited near a nerve, and it's between the site being that we're depositing it and the brain or the spinal cord, because it goes straight to the brain and the central nervous system. Remember, it's the brain and the spinal cord. So it's a chemical barrier that prevents the pain impulse from even reaching the spinal cord or the brain. So anesthetics, local and topical, injectable and topical, when they are trying to find a good anesthetic or when they first were developing other anesthetics, after they realized cocaine was not working because people began to be addicted to that. And so they realized that they had to find something else. And so they started working on other things. And so the best way was if they could find an anesthetic that they could make into a topical to numb the gums, and as well use that same formula to make it into a liquid. They just didn't have much luck except for a few. Lidocaine is one of those few. Lidocaine has a topical lidocaine, and it also they can have it in its liquid form to be an injectable. The other one is tetracaine, and that's effective both topically and by injection. You just don't hear a lot about it because lidocaine is an amide, which means that it doesn't have as much allergy issues with it, and tetracaine is an ester. So it does have possible allergies and other things, side effects going on with this. So mostly we don't have tetracaine. Why take that kind of a risk when lidocaine is so good? So lidocaine happened to be so awesome, exactly the way that they wanted it, that we measure every other anesthetic that they even come up with is measured. Like, how can we have this different anesthetic, but that does as well as lidocaine? It needs to do at least as well as lidocaine, or why even have it? So it's always the benchmark. So diclonine is a potent topical, but it's too irritating to the tissues, so they couldn't use to be injected. Procaine and mepivacaine. Mepivacaine is what we use. We don't use procaine anymore in the industry, but mepivacaine we do, and they are very potent injectables, but completely ineffective as topicals. So that's why they come up with the two that are. So we have desirable effects that we want in a topical, and none, even lidocaine doesn't meet all of the desired effects, but a majority of all of the anesthetics that they have, I mean, most of them meet a majority of the good, desirable effects that we want to have. All of them will prevent both the generation and conduction of a nerve impulse. I would know that. They prevent the generation, so even it going any further when there is some kind of a impulse, it prevents it from generating further, and the conduction of it going further of the nerve impulse. So it's setting up a roadblock between the pain source and the brain. So these are the desirable properties that would go. I used to have the students write all 10 of them, but I'm not having you guys do that. I'm sure you'll be happy about that. You want them to be, of course, a non-irritant as much as possible. Everyone has to be reversible. Local anesthetic is reversible. You come out of it. You don't just get anesthetized and then that's anesthetized forever. You want them to have a low systemic toxicity when it's going through your body. You need it to be effective, of course. And the desire would be to have a short onset of action. Unless your idea is you want to make one like bupivacaine that purposely has a long onset or longer onset of action, and because it will cause it to last a lot longer. But all of the other anesthetics, you don't want to have to wait 10 minutes for it to take effect before you can start your procedure. You want it to take effect the shortest amount of time possible. Even sometimes waiting at least 2 minutes for it to, or 3 to 5 minutes for it to take its effect seems like an eternity because you're on the clock and you want to get started. So you want it, even though you want it to numb in a short amount of time, you want it to last the longest that it possibly can, so you don't have to stop your procedure and re-inject for your time, but also more importantly to be penetrating more holes in your patient, because every time you do that, penetrate into the tissue, there's a possibility that when they come out of the anesthetic, they're going to be sore there. So you don't just want to use them like a pin cushion and be doing that. We want to do that as least amount of times as possible. So naturally, you want it to be potent enough to numb. You want it to be non-allergenic. You want it to undergo rapid biotransformation, which kind of hooks up with low systemic toxicity. You want it that if it's in your body and it goes to certain areas to break down and then to be eliminated, you want them to do that quickly and not hang around in your body building up a toxicity. So you want it to go through a really quick breakdown or biotransformation. They should need to be sterile or capable of being sterilized by heat without it deteriorating. So I know that epinephrine, when you put a vasoconstrictor, such as epinephrine, along with the local anesthetic, the heat can cause it to deteriorate and then it's not as useful. So you want to be capable of being sterilized by heat means that the heat would be not that much. Okay, not they really have to keep control of that. So now we're going to go back and review from probably prior science courses that you've had, the nervous system. So the central nervous system, the CNS, is just the brain and the spinal cord, easy to remember. And the PNS, which is the peripheral, goes to the peripheries of your bodies. Your peripheries are what goes away from the core, which means your arms, your legs, everything that goes off to the side. And so all else is from the periphery. And what local anesthetic deals with is the central nervous system. It's going to deal with what goes to the spine because it goes up to the brain. So we'll review a neuron. A neuron is just a name for a nerve cell. And the impulse travels down an axon. So what this is an axon. Can you see my cursor?
Yes, we can.
Okay. It probably just won't be on the recording, right?
Yeah, no, on the recording, all we can see is when you actually draw on it. We can't see your cursor moving.
Okay, I'm not sure I can draw on this, but I will go ahead and just do the cursor for now and try to figure that out later. This is a nerve, it's an axon. You have a dendrite at the here that are kind of tree looking things with fingers like a branch or something. And this is what is usually closer to the skin, the first one. This will be closer to your skin to where it's feeling an impulse. If you bump into the skin, it's going to receive that impulse or that stimulus or excitation, or there's many action potential, are all names for the impulse. And so it receives this and it goes down this axon and it comes out over here to the axon terminals. Now these also look like branches, but they often have these little ET fingertips on them, is what I call them. And this is what is going to go eventually into a muscle to cause your muscle to jerk back from the pain. So until it gets there, these can be quite long, but a lot of times they connect. There's be another one up here and it will connect. There's this blank space which is called a synapse, and it has to kind of jump over that synapse and go on to the next axon, and it does that, keeps connecting like that until it reaches the spinal cord, and then it kind of turns around. So this is a sensory neuron actually, because it has the cell body outside. So this impulse doesn't go down and then come through here and go loop-de-loop and go out. The impulse just goes down here. And the reason all that the cell body on both are for is for nutrients and to supply the cell. So the impulse doesn't have to go through there. So they have what I call these little hot dog buns. They're called myelin sheaths. And so there'll be gaps in between them here, and they just have these myelin sheaths every few millimeters. And on the outside of the sheath, it has its nucleus, which are these circle things or oval. And it's always on the most outer side of the sheath. Then the sheath is going to wrap around like this. And on the very top part of the sheath, you'll see a nucleus. And so that's how you know it's a Schwann cell. And because it looks like that with the nucleus on the outermost covering of the myelin sheath. So the whole thing, the line is called an axon, and the dendrites will go ahead and this will go ahead and the impulse and travel down, but it travels down in one direction, and that's what you need to know. It's called the all or none theory. You either have a stimulus or you don't. So it doesn't do this and then kind of turn around and come right back, or go up here, loop around and come back. It goes down toward the synapse, toward here, in one direction. Once it starts, it goes. It may not be real strong. Maybe you were just bumped like on a door, but it wasn't excruciating pain. So that's a stimulus, and once it starts, it goes ahead and comes down, but maybe it's not real full. And so, but it still will go ahead and make that travel on that way. So that's called the all or none theory. It's where an impulse travels down an axon in one direction toward the synapse in a sensory or motor neuron. It can be in both.
So this being a sensory neuron, this is part of the afferent nerve system?
Yes. Yes. So these would be two directions. And if you're getting this or you already get this, I mean, someone who doesn't, let me know. Because if you're getting this, I won't spend so much time on it. But anyway, you have a unipolar and a multipolar. I don't really see the unipolar and multipolar words in review books, but I do see sensory and motor, afferent and efferent. So you can see where this motor neuron has the nerve cell, and the impulse does go through it. But this cell body, and that's the main difference that you can tell between motor and a sensory, is the position of the cell body. Now they do different things. The sensory neuron is going to take the impulse here. Let's say that this is skin and you get pricked by a needle. It's going to take that impulse and it's going to go ahead and it goes toward the spinal cord or the brain. It's going to keep going until it reaches that part. At that part, there's a little tiny, it's called an interneuron, where that kind of makes the circle back around. The impulse of pain has now reached the spinal cord, which is then going to tell the brain. And then it hooks up with this interneuron, which just connects sensory and motor neurons together. And it kind of goes through there, and then it comes back on a motor neuron. Think of motor as movement and motor as muscle, two M's. It's what's going to go to whatever part of your body has been hurt and cause it to jerk away. Okay, and it happens just in a nanosecond. So, okay, I think that's later. So once again, I have many different examples here. Students prior some were they needed more explanation to see how this really worked. So here's your skin or mucous membrane here. They have it depicted by this, and it gets pinched or whatever. And here's a receptor cell, kind of like an interneuron cell. It's just a tiny little cell that will take it and it hooks up to sensory because the cell body's on the outside. And it takes it up. This is supposed to signify the central nervous system or the spinal cord. which is shooting the message to the brain. So then here's this little tiny interneuron, which just is going to connect a sensory to a motor, and it takes it back the other way. And these little ET fingers on this side are hooked into the muscle, which is causing you to take it away, the muscle away. Here's another example of the same thing. You can kind of see yourself that this sensory is going to, here's the interneuron, here's the spinal column, and it takes it this way and into a muscle. Okay, Beckerly just, Director Beckerly just emailed me and said that she hears that you have a lot of questions, and so she's going to jump on at the end of our course. So, okay, so about 11:30. So here also, the same when you stub your toe, you can see, I don't know why that keeps happening. When you stub your toe, you can see that the sensory receptors take it to a sensory neuron, and it's going to take it all the way up to the spinal cord. And then it's hooked with an interneuron, and then it goes back and hooks up to your thigh and tells you to pick up your foot or your toe because it's hurting. So here you can see the difference between, once again, motor neuron and a sensory neuron. This is going to a muscle or whatever, and here's the skin or the tissue where it's coming into. So this is the structural unit of a nervous system. There's sensory and motor nerve cells or neurons. That's it. But there's three parts of a sensory. You have the question. You have a dendritic zone down here, which is going to receive the stimulus, and it has branches and nerve endings. And then the central portion is the axon, and the cell body is the third main portion. So it doesn't really call this is a function of it, but it usually always will say that there's only three parts. The dendrites, the axon, and the cell body. Same with here. These are dendrites out here, and the cell body and the axon. Oh, she asked a question. I need to answer her. Okay. All right.
On
Go ahead.
sorry, on the axons, so it says like on the nerve cells, the mesial end has branches which synapse with the CNS. Is that like, I mean, do they literally run all the way to the CNS, like from like your toes?
Yeah.
Oh, okay.
Some of them can be really long, and some are short, shorter ones all hooked together. And whatever, it literally runs, and connects with another sensory, or it can be that long. They have some that are quite long, feet long, and it goes up and all has to connect and then come back on a motor neuron to tell you to take your finger off that burning stove. So, or burner. So the thing is, how fast that happens. So all that's going on between you putting your finger there and you removing it. So the function of both cell bodies is to provide a metabolic support. So here's just another picture of a motor neuron. So we're going to talk about the axon. It's a cable-like, also, I call them hot dogs, but they're cable-like structure made of cytoplasm. They will use axoplasm. It's the very same word thing as a cytoplasm, but they'll interchange these words. So don't think, if you see these, don't think it's a word you haven't seen. So surrounded, it's all this axoplasm, and it's surrounded by multi-layers of that lipid membrane. And so on the outside, remember, of that membrane, or the hot dog bun, there is the nucleus, which is going to make those into Schwann cells. It can be quite long. They've measured some 6.5 feet long. So you know how they're intertwining in your body if you're only like 5 whatever feet tall. They're intertwining everywhere. So axoplasm is separated from extracellular fluid by the lipids. So it's just saying that all of this on the outside is the extracellular fluid in our body. So it's just saying that the cytoplasm or axoplasm is separated from out here by those sheaths. So in some nerve membranes, they are covered by this myelin, and it's lipid rich. And the myelin sheaths are specialized forms of Schwann cells. The nerve cells covered by myelin sheaths are called myelinated nerves. So there's questions about that, and it seems pretty obvious to me. If it's covered by myelin, it would be myelinated, and yet we have people get that wrong. Myelinated nerve fibers, and what those do is that they help increase the speed. If you have those Schwann cells that are the myelinated sheaths, when an impulse goes across, it helps it skip across a lot faster. So the nerve cells without that sheath are called unmyelinated nerve cells, and they're a slower impulse speed. Okay, I'm trying to, there we go. So once again, on a motor neuron, here's the dendrites all out here, and then the dendrites are hooked to the cell body, and this is what's going to receive the stimulus, and it just kind of goes right through the cell body. And some questions will call this the soma. It's like the dendrites on a motor neuron, the impulse passes through the soma. What they're meaning is the cell body. So those two words mean the same thing. So they go along, these don't show very wide of a gap, but there is a gap, and then it goes to the nerve axon terminals. And actually these would hook to other ones until it gets to your muscle. So Schwann cells are present in the outermost layer of myelinated nerve fibers. There's regular gaps in between. These gaps right here they are in between these myelin sheaths, and they're called nodes of Ranvier. And nodes of Ranvier, that's where all of the local anesthetics exert their action. So it's going to be here. They don't go through this sheath. If you have a needle and it's coming right here and you drop a lot of anesthetic and it's going here, we want it to, it's acting on these nodes like here and here. Okay, so they're called nodes of Ranvier. So sensory is afferent, motor is efferent, and like I said, you may have a different way to remember it. You could, sensory is incoming to the spine. It's always going toward to give the message that something is in trouble. And I always put say me. You could put the word together and just have the word same, but just remembering that sensory afferent and motor efferent. So I usually don't connect just the same word. I'll just say me. And I know then that if they ask me, is an afferent neuron a motor cell or a sensory, I have to go back to my say me. It has to be sensory. And you can think of any way that helps you better. So the sensory.
Sorry, can you say that one more time?
The what?
About the sensory to me.
About the say me?
Yeah. You said something.
Yeah. Sensory is afferent. So I have SA, which I call say. So I'll call it say, and then the motor is efferent, and the two first letters of those words are E, so I call it ME. So I'll just think say me, that I know if it asks me if something is efferent, I know that that goes with the motor, If they ask me a sensory, I know it goes with afferent. If they ask me afferent, I know it goes with sensory. I just put those two things together.
Thank you. Yeah, I missed the me part, but yeah, thank you.
Okay, so sensory neurons are activated by sensory input, like your hearing, your taste, your touch, your smell. All your senses are affected, activated with the sensory neurons. So those impulses are carried toward the brain, and they're afferent. Impulses carried away from the brain or the spinal cord. The test question could say either one because they're kind of one and the same. The brain and the spinal cord would be, if it's carried away, it's efferent because it's carried. And just think of, if it's motor, it's going to eventually to some type of muscle to remove yourself from the situation. Motor neurons are located in the central nervous system and directly or indirectly control muscle. All right, so now we're going to talk about the nodes of Ranvier. These are channels. Like if you just took the outer skin, I should call it by its name, the membrane of that blank space in between two hot dogs or Schwann cells, that's the node of Ranvier, where like I said, the anesthetic takes effect. So how it gets in is it has this, if you took it under a microscope, it would look something like this. So interspersed through there are channels, those blue channels, and it allows negative and positive charges to kind of come back and forth in and outside of the nerve cell. So down here would be the inside of the nerve cell, and this would be all the way around the nerve. They're just taking a cross section of it. So when the local anesthetic comes in, if it is deposited, it's going to run toward here. It's going to run, encompass this. It's liquid, and it's going to be all around this, not just on top. Okay, so it is saturated all the way around, and all the way around you've got all these channels. And some are, you've got, here's cholesterol, glycolipid with a carbohydrate attached, glycoprotein attached, but peripheral membrane proteins, you need all these things. But what we're the most interested in are these channels, the ones that will let positive and negative charges come in and out of certain chemicals. So the nerve actual fibers will carry information. We know that from one part of the body to another. All those nerve axons, they're all made up of nerve fibers. So the message is in the form of an impulse, stimulus, or an action potential. And a lot of electric action potential. A lot of their test questions will say, what causes an electric action potential to blah, blah, blah. So you need to know that those are interchangeable words. Once the impulse is initiated, the amplitude doesn't change regardless of a change in the quality of stimulus. So all that's meaning is that once like you would go like this, it doesn't loosen. It takes that impact and throws that impact all the way to the spinal cord. It doesn't, even if you get hit again right after that. The first one is on its way and going, and then you'd have another one going. Okay, it doesn't like override anything. So the interior of a nerve is negative relative to the exterior. And here we're going to get into the resting potentials. The nerves have a resting potential, like right now, at rest, I'm not hurting anywhere, and the inside of my nerves is a negative 70 millivoltage. Okay, so that's at rest, and I'm considered polarized because my nerves are polarized because there's nothing, I'm at rest. There's no impulse going in and out.
I got a quick question.
Sure.
What was the state? It says state another name for an action potential.
Okay, you right here, you see.
Oh, it's just called impulse or okay.
Yeah, electric action potential, impulse, or stimulus.
If the inside of that is negative,
Yes,
okay, and the outside is still negative, or is that positive?
it's positive. When it's resting, it's negative on the inside, positive on the outside. So that's why it's like they're talking right here about the inside of a nerve has a resting potential of negative 70.
Thank you.
Uh-huh.
Anna, sorry. And when the one that says know where local anesthetics exert their action, is that the nodes of Ranvier?
Yes.
Okay, thanks.
So electrochemistry of the nerve. So here you go with this is completely around, and that picture I showed you with all the channels, the blue channels and all the glycoproteins, that's what's on the top of these kind of roped nerve membranes. Okay, they just took one round nerve membrane and cut it in half, cross-sectioned it. So on the outside, in a polarized resting potential, the inside of the nerve has a resting potential of negative 70 millivoltage. So the outside is mainly positive. It has a lot more things out here, but what we're concerned with in pain is the sodium. Na is sodium molecules or ions, same thing. So outside of that nerve membrane, it's mainly and close to the nerve surface, it are tons and tons of sodium positive ions. On the inside is this cytoplasm or axoplasm, same thing, and it's mainly negative. It does have a positive potassium here, and it has a positive other couple things like hydrogen, H's. They're just not showing it here. But the main part of this, the whole thing is negative. So even at a resting state, you remember those channels. A few ions still escape through, and so a few of these sodium ions can kind of escape through, and the potassium can go out, and the calcium can get through. So even at rest, the nerve is slightly permeable to sodium ions.
I have a question.
Sure.
Right now, are we looking at the node of Ranvier?
Yes.
Okay. Thank you.
Uh-huh. So at the node of Ranvier, if you're going to go into this nerve membrane is very slightly permeable, meaning that these things can escape. They're not meant to, but some just work their way through. So even at rest and polarized with a negative 70 millivoltage, the nerve membrane can be slightly permeable and let sodiums through, but not enough to do anything. Okay, so then there's a firing potential. Okay, so then you have a stimulus come in. You get someone puts a pin in the side of your arm. So then all of a sudden, it's an impulse, and the impulse comes in through to the sensory nerves, and it goes down the axon, and it's hitting when it goes down here, that axon, it changes the millivoltage from positives and negatives begin to change. So it will say if it's a negative 15, it will kind of go up, or I mean, not negative. There's a positive 15 millivoltage difference. Then and all of a sudden that's the negative 70 isn't negative 70 anymore. It's maybe anywhere from negative 50 to negative 60. And they say that, but most of the time it's just plain 15 difference. It can all of a sudden then big changes start to happen, and the channels start opening, not a lot, but way more than when they were resting. You're going to have channels open, and they're going to allow a whole lot more positive sodiums to come in here. All of a sudden, it blocks the potassium from going out, so channels are opening and closing, but what we're interested in are what's going on with these sodiums. So it's called slow depolarization because maybe it's going like a 1 millimeter voltage difference and then a 2 millimeter voltage difference, and it shoots up. If it only goes up to a like 13, it doesn't hit 15. It goes up to like a 13 or a 14 even millivoltage, then it can stop. The firing action won't happen. Okay, they're the rest of the pain. So that's if you just get, kind of bump yourself like this and it kind of hurts, but it's not excruciating. All that's going on, but the voltage of that stimulus isn't strong enough to have everything else happen. So it just kind of goes back. But when it is more painful, as soon as this gets to a 15 millivoltage in here, which is going to reduce this, you're just going to subtract that 15 from 70 or add it to negative 70. You're going to get somewhere, and it will go somewhere between a negative 50 and a negative 60. That's called slow. And then all of a sudden, right after it hits the 15 mark, the floodgates open and it's going to go real fast. All those channels, and there's tons of them, all those sodium channels open up like this bright, and tons, you can see by this big fat arrow, tons and tons of sodium come through. And this is happening everywhere along here, along both sides. So tons are on all sides. So tons of sodium, positive sodium are coming in here. And that's rapid depolarization. It's no longer normal or polarized, it's depolarized.
I have a quick question.
Sure.
So it says the resting potential charges of a nerve, and the inside was negative 70 millivolts. The outside you said was negative as well, or is it positive?
It's positive.
Okay. Do we have a specific charge for that or no?
No.
Okay.
Not that I know of. So then the floodgates are going to open, then a multitude freely pass through during this rapid depolarization. And now the inside is positive and the outside is negative, because so many positives have come through here that's negative on the outside and now positive on the inside. And so you have, it's just reversed. The voltage across here has just reversed itself. Okay, so then it starts to go back, it's trying to go back to normal. So it's a repolarization, it's trying to repolarize. So then all of a sudden the channels will close, that will close, allowing any more sodiums to come through. That closes. But a big channel opens to where a lot of sodiums are coming back to the outside. And so that makes it returns back to its normal. I mean, it can anywhere from negative 60 to negative 90. It can be repolarizing and getting back considered back to normal, even though it's not just 170. It's going to get to 170, but somewhere between negative 60 and negative 90, it's trying to kind of fluctuate itself out. And that's it trying to repolarize and reverse itself. So the electrochemistry of a nerve conduction is you have your resting membrane potential, you have a stimulation or an action potential, electric action potential or stimulus. Then you're going to have slow depolarization, and this is where the anesthetic takes place. It takes place on the nodes of Ranvier, but in the actual on the inside of the nerve, it takes place during the depolarized parts. Okay, the slow and the rapid depolarization. And that's just 0.3 of a millisecond. That's how fast that these impulses are, which I find fascinating that it all can be done in that short of amount of time. But and slow, from going from slow depolarization to rapid is the 0.3 of a millisecond. And all the anesthetic action takes place during just when this whole thing starts to where it goes to rapid. It's the whole depolarization So then it's going to try to recover and repolarize, and that repolarizing and going back the other way with the charges reversing takes like 7/10 of a millisecond. So the whole thing takes a millisecond. It's just the depolarization taking 0.3 and the repolarization taking 0.7. I've seen questions about this. I've seen them to where they're saying, you know, how many tenths of a millisecond does it take? It'll have this, the repolarization or the depolarization, usually not both. And then they'll say the whole process from depolarizing to repolarization takes how many milliseconds, and so that'd be 1. Okay, so then it's going to do that, and then it goes through an absolute refractory and relative refractory period. So the absolute refractory, it means that immediately after a stimulus has been initiated, potential, the nerve's unable for a time to respond to another stimulus, regardless of its strength. So it lasts about for the duration of the main part of the action potential. So you're talking that for like a millisecond of the depolarization and repolarization, if it takes a millisecond to happen, then if you got hit, you know, if you got hit like this and someone could hit again just in a millisecond but harder, you wouldn't feel that second hit if it happens within the millisecond, because you can't receive another stimulus for about a millisecond, even if it's stronger. So the relative refractory period, it's going to follow that absolute refractory period. It's when a new stimulus can be initiated, but only if it's stronger than normal. So right after that millisecond deal where it can't, let's say it took, you know, let's say it took 5 seconds or something to, or a second to go ahead and hit again. Then if as long as it's after the 1 millisecond, you could feel that second one, if only, but only if it's stronger than the first one, if someone popped you and then popped you again.
This sort of makes me think of like when women wax, they like slap it afterwards. You know what I'm talking about?
No.
I
So,
know
like-
what you're talking about.
Yeah. So it's like, you know, you try to like just beat it so it doesn't hurt anymore, I guess.
That's funny. That so when they wax, I've never had my like legs waxed or anything. So they, after they pull the wax off, they slap it.
Yeah. Yeah.
Mhm.
And it
Yeah.
does make it feel better because you're not like focused on that pain. It's like, you know, trick.
Focus on another pain. Oh, that's funny. That's funny. Interesting. Okay, so now we're going to talk about the impulse speed between those myelinated fibers that are surrounded with the Schwann cells and ones that are not. So the impulse speed, how fast they go, it's going to be different between myelinated nerve fibers and nerve fibers that don't have those, like the nodes of Ranvier, don't have those, that myelination around it. So the unmyelinated nerves usually have slower conduction impulse. That's the one over picture on the right over here. But the myelinated ones that have the sheaths of fiber around them with these nodes of Ranvier, that's the fastest. And it's fast because the impulse can skip from one to another. And when it's like this, it just has to go through every single one of those. So it's slower here than here because the impulse can fast skip.
Okay, and I sort of remember that, but which ones are myelinated and which ones are unmyelinated? Is there something that goes with that?
The myelinated ones are the ones that have, like these have sheaths.
Yeah, I remember the sheath, but I just don't remember which ones are myelinated and which ones are not, because some of them are and some of them aren't, right?
Right, like this one would be, this one would not be. So if you had a myelinated, are those Schwann cells? Is that, am I answering?
Okay, okay. Thanks.
I have a question.
Cells would be the myelinated ones, and the part of the axon that doesn't have, some axons don't have any of that. It just
So,
has
Is it like, sorry, I have a question. Is it like some sensory and some motor are myelinated and some aren't, like both sensory and motor?
I think both can be both.
Where, like in the body, or I guess, I don't know, like would there be more myelinated nerve fibers and then like more unmyelinated? If that makes any sense.
Yeah, it does make sense. Interesting. Good question. I'll find out.
I sort of remember that from anatomy, but I can't remember how that works. But yeah, I remember.
So do the impulses skip on the myelinated or both or neither?
They skip only on the myelinated.
Okay.
They do on the unmyelinated, there's nothing to skip to, so it just goes straight across instead of being able to go like this. So the conduction obviously would be faster in the one that can skip. So this would take a little bit longer. So the impulse conduction, it's faster the larger that they are. Like if you had one that had this and it was fast, but then you had a nerve next to it that was a larger nerve, then and thicker, larger, it would be the fastest. So the larger myelinated fibers, axons are even faster than the smaller ones. And that's a quiz question, I think. So here's where it becomes important for us. It becomes important because sometimes one of these nodes right here of Ranvier are blocked. And we don't know why, okay? And so the impulse can't stop there. It will skip. And it will skip that and go here. And it can even skip like 2 nodes of Ranvier. It can skip up to 2 or 3. If the impulse is going to this node of Ranvier and for some reason it's all blocked up, and then will skip over that and go way to here. And the reason that that's important is because when we're giving local anesthetic, we want to go as close to a nerve as possible. And we need for that anesthetic to be able to hit at least 2 to 3 nodes. Because if your anesthetic only hit, like was given way up here and was given kind of far away from where we wanted to give it, and so by the time it got down here, it was dispersing in all these places we don't really need it, and it finally hits the nerve and just a little bit trickles down and it gets over this node. So let's say that node is blocked. So we give it, we think the patient is numb, and we get in there and all of a sudden they're like, ow, I feel it. And you're like, well, how can you feel it? It could be because you're further away from than you thought, and maybe not enough nodes were anesthetized, and maybe it's the impulse of pain skipped over what was supposed to block it. So it just skips over and goes on and registers as pain instead of being blocked. So we want the anesthetic to be like here and block those impulses so it stops right there and it can never get to the brain.
So you might be going over this here in a little bit, but does the local anesthetic, or does the anesthetic like basically attach to the sodium and then it like goes into the nerve via the depolarization process? Is that how that works?
Yes. The anesthetic, allows, what it allows for is for the sodium to go into the nerve and to be eventually blocked. So no more sodiums can come in, so it can anesthetize. Yeah, we'll get to that in a minute.
So On the 2 to 3 nodes that have to be covered, you know how like you said they can be skipped or blocked and we don't know why? So is there never more than 3 blocked in a row? Is that why it has to cover 2 to 3 nodes?
Yeah.
Since
They've never had it, or it hasn't been shown that it's blocked up to 4. So they're like, we think that it's 2 to 3 nodes. We want it to cover the anesthetic so it can cover this one in case this one's blocked. And so the speed if that's blocked, that impulse is going to go right to here and then be blocked and won't be able to get any further. Or maybe 2 of those are blocked, but rarely well over 2 or 3 is how I take it.
okay,
So what that means in length is only about 8 to 10 millimeters. So think of your probe. Okay, so every 8 to 10 millimeters is 2 to 3 nodes. So it's really not all that long.
So if it's blocked for not from the anesthetic, but for the unknown reason, then obviously it doesn't have it can't feel pain, and that's why it skips to the next one. Does that make sense? Is that why we have?
Yeah. If it's blocked, that part is not going to feel anything,
and it will just go to the next.
Pain impulse will just skip over that.
Okay.
Like it's deadened, it'll just, that door's closed and it just skips over that and goes to the next place that it is going to stop. And if there's local anesthetic there, I keep forgetting you guys are this way. If there's local anesthetic there, then it's going to have already taken hold and it just stops and it can't jump anymore.
So with the unmyelinated, is that process the same?
With the, yes, it would need to get over there, but then, well, yes and no. On the unmyelinated nerves, they don't have like nodes of Ranvier per se, so the local anesthetic isn't even going to get on there. I mean, I don't think that's a process.
So since the impulse is slower, do you just not feel it then and you don't need anesthetic?
Yes, but well, it's kind of I'd have to explain a little bit more. Let me, and there's a part of unmyelinated that they don't even go through. So I'm thinking kind of that's not even an issue, but I will kind of do some looking on that. These are all good questions.
So with the unmyelinated, it has the slower impulse. So
Right.
Someone that has like trauma, would they have like a slower impulse to like leg pain if they like were handicapped?
Yes, maybe so. Maybe so that it would have a slower impulse in order for it to reach. Yeah, I guess so. And
Okay.
I really never thought of it that way, but it's true. You know how sometimes something can be, instead of like direct pain, it can be more throbbing.
Yeah.
Yeah, that's interesting.
Do we deal with unmyelinated like when we're giving anesthetic?
No, I mean, we don't really, it's not really a thing that's talked about. Most of our dealings or any questions that are going to come, I think about the only questions that I ever see about unmyelinated nerves cells are the fact of if it's slower or faster.
Okay.
Okay, so that's about it on that. So this is called saltatory conduction. The saltatory conduction is the fact that it skips. It's running and skips over. That's the saltatory conduction of a nerve cell. So now we're going to get into classifications. Nerve membrane is the site where so the LAs exert their pharmacological action. The pharmacological action of a local anesthetic is affected on the nodes of Ranvier, right? So that it has to get through that nerve membrane of the nodes of Ranvier. So that's where we have the repolarizing, and you have all that stuff taking effect on the inside if there's a pain stimulus. And when the anesthetic comes, we're hoping to block that pain, before pain even maybe starts happening, then the local anesthetic, it would be true that a local anesthetic exerts their action on the nerve membrane. Okay, so if you get a question like that, that is the nerve membrane of a nodes of Ranvier. Only your question may not have all those parts. It does exert on the nodes of Ranvier, but on the nodes of Ranvier, it exerts its action on the actual membrane on the outside. That's what starts the whole numbing. So they're classified by their ability to react with specific receptor sites in the sodium channels. So remember that picture with the blue channels coming from the outside of the nerve to the inside, where the axoplasm is. Those are sodium channels that are specific to allow sodium in and out. It doesn't allow potassium in and out. It's just strictly for sodium, and they're sodium channels. So on those sodium channels, if you like you have your nerve like this, the up and the down, and the channel will be, open on the outside and open on the inside of the nerve, and the channels to get from the outside to the inside. Does that make sense? So in that channel, there are receptor sites that are specific to your local anesthetic and specific to sodiums or positive charges. So what the whole theory is that the sodium goes in through those sodium channels inside the nerve, and in other words, it's and it changes it's now more positive on the inside, right? So then those channels allow positive charged ions, molecules that are in your anesthetic molecules, to go in through those channels, and it hooks up with a base. Will hook up. Oh, you're not going to understand this let me wait till I get to that part. I think it's easier to understand on that. Just for your knowledge, there are quite a few theories about how the effect of the local anesthetic even works and why it works. And the only one that this is the theory. You don't even have to read about the other theories. I've never seen any questions about the other theories. The one that most dentists will go for is this specific receptor theory. That's the most favored with all the dentists of all of the different theories. And all that it's saying is that the local anesthetic can alter the nerve conduction in at least 4 sites in a channel. Okay, so it can alter it on receptor sites, can be within the channel, it can be at the top of the channel, it can be at the bottom of the channel, or it can be on the outside of a channel. You can have different receptor sites for different chemicals, and it eventually blocks that channel, and that is what the most favored, and that's why local anesthetic can work. So all you need to know is that the specific receptor site is the most favored theory, and that they believe that there's 4 sites within one of these channels, and at either one of the gates, open and close, and open on the outside and inside, and within and on the outer. That's all you need to know. Don't even worry about understanding anything else. So they have A drugs, B drugs, C drugs, D drugs, and the way that we are concerned with the C and D drugs in local anesthetics. So we're not going to go through the A and B at this point. So C drugs exist only in an uncharged form, and this is how we're going to get into kind of what I was trying to explain before. The C drugs, like benzocaine, an uncharged form means a base. It's not an active charged form. It's an uncharged base. And so you have this It's just called capital R, capital N. And the class C drugs exist only in that form. And that's like benzocaine, which stays on the outside of the tissue. That's our topical. Class D drugs exist in both charged and uncharged forms. So it's charged ions or molecules and uncharged, the base ion and molecule. And the class D drugs holds most of our anesthetics that we use. This is, because this is a topical on class C, this is a lidocaine on class Ds. And so these don't have charged forms, they only have base forms of RN. These have both charged and uncharged forms. So they're the most useful agents. So we go to class D. And the reason this is important to us to know is because when some health issues will say don't give class C drugs to, okay? When we are, when a woman is pregnant, we will not give them a class C drug because it has things in it that are not good for them to have. So it's class D. So right now, all you need to do is just accept this knowledge, and then we'll get into the whys and wherefores at a later time. So lidocaine, articaine, prilocaine, mepivacaine, those are all class D drugs. They have both charged and uncharged.
So does charged and uncharged have anything to do with whether or not it's injectable or just topical?
Or
no?
Yeah, it can. It has more to do with the fact that whether it's charged or uncharged has to do with the fact that that part of the local anesthetic can even get into the nerve to numb it. Only bases can get into the nerve. So only the RNs can get into the nerve as far as the actual ions go. But as far as being able to tell which is a C drug and a B drug, I don't know that just all C drugs are topical. I don't know that to be a fact. But this would be, benzocaine is considered a C drug. So sodium channels are very abundant at those nodes of Ranvier with myelinated fibers. They are just tons of them. So local anesthetic in a solution is going to exist in both, like I said, uncharged, the base, RN, and the charged ion or molecule, same thing, which would be RNH positive. That would be the charged form. So the measure of strength of the tendency is called a dissociation constant. That's what the pKa is. What I've seen questions about is just wanting to know exactly that. What does pKa mean? It means they could either say, the answer could either be dissociation constant, or it could be the measure of strength of the tendency. So the strength of the tendency might be the strength of the impulse. Okay, so pKa values for local anesthetics range from 7.7 to 9.3. pKa is different from pH. The pKa on page 17 in your book, you can see, I think it's in there, you can see a list. We have a new book. Yeah, it's on there. On 17 in your book, you can see a list. And the list will have a column. It'll give the agent, whether it's benzocaine, mepivacaine, etc. And it gives a pKa right next to it. And you can see down there that the pKa runs like from 3.5 here to 9.3. And you don't really need to know about the other two columns, the base and all of that. You won't have any questions over that. But you do need to know something about the pKa. It's very you have to pay attention to it like you do a pH. They do kind of work interchangeably. And the pKa number, they used to have, when they send you anesthetic, they used to have on the sheet, they would list a PKA number. The PKA of this mepivacaine is such and such. And so what that would tell us, we didn't go through any chemical whatever, but all that we knew is that the lower that the PKA number is, the shorter the action, the faster it's going to numb. Okay, so if you get something that is really high, bupivacaine is an 8.1, and its approximate onset of numbing says 5 to 8 minutes. You get something that's a 7.7, it could be anywhere like 2 to 4 minutes. That's mainly what, and it's usually about 2 to 3. But the book says kind of 2 to 4 minutes, and you can see that the majority of that we use are those 2 to 4 minutes, and they're all around 7.7 or 7.8. As you start getting higher, like your bupivacaine, that actually takes a little bit longer, but they're going to say 8.1 and 5 to 8 minutes. So if something took 8 minutes to even numb, that's not really a great one to use for hygiene when you're on a schedule. So it will go on and on. You can see Procaine, which they don't use anymore, was a 9.1 PKA, and it took like 14 to 18 minutes for it to even numb in the first place.
So the stronger it is, the longer it takes to numb.
Exactly. And
If
that's the part that you need to know about the PKA.
We have a question that says, state the meaning of acid dissociation constant. Does that have to do with the PKA?
Yes, it does. And we'll get to that in just a second.
Oh, okay.
So the primary action of local anesthetic is to produce a conduction block. You want to block so that the pain can't go any further to the brain or spinal cord. So you want the local anesthetic to alter the resting potential. Okay, and alter that. You want it to alter or numb the threshold potential. You want it to decrease that depolarization where the potential is going up and up to the firing. You want to decrease all of that, kind of stop that from happening. And if it's going to happen even a little bit, you want to prolong it repolarizing. So you want to numb the depolarization part so it lasts a really long time and it doesn't come back for a really long time. That's when we're doing our scaling and root planing. Okay, so that is what we're wanting the effect of the local anesthetic to be. So the primary effects of the local anesthetic occur during the depolarization phase, during the slow and rapid depolarization. So the sequence is this. In order for there to be blockage, there's displacement of the calcium ions from the sodium ions in the channels, and just know that. It's going to permit binding of the local anesthetic molecule to the receptor sites. So the local anesthetic is going to go through and it's going to allow it to bind to all those receptor sites in those channels. So that's going to result in, it won't allow any more sodiums to come through because it's blocking. And sodium's coming through is what's going to further the pain sequence. So we want to stop any more sodiums from coming through. And so that anesthetic is going to go up and from the inside of the nerve up and block those channels so no more sodiums can get through. That's the basic deal. So there's a depressed rate of depolarization. It's a failure to achieve the threshold, that firing threshold. If it's numb right there, it can't ever, if we're scaling on a tooth and it's like should be hurting them a whole bunch or whatever, then it's being blocked. It can't ever get to that 15 millivoltage change, that firing potential, because we blocked it. So then there's a lack of action potential or pain potential going forward, and then you have conduction blockage. So most local anesthetics, and this you just have to memorize. There's no point I've never seen anything that takes a question that puts up a chemical structure, like drawing the hexagons and the circles and drawing the lines in between, saying all of that. And that's what this is kind of referring to on amines. Most local anesthetics are tertiary amines. There's primary, there's secondary amines, and there's tertiary amines. So tertiary would be the third set of amines. Only prilocaine and hexylcaine are secondary amines, and hexylcaine is not used much. I don't even know what it is. I never hear about it. It's just saying there's another one. Prilocaine, we do know about. So in order to make it a secondary amine, the chemical structure is just a little bit different. But everything but prilocaine and hexylcaine are all tertiary amines. These are secondary. So I've seen questions about that. That's why it's in red. The tertiary amines, it'll talk about them having, whether they have a lipophilic or a hydrophilic part. And there's a picture of this in on 15 and 16 of the structures. So we don't have to memorize or know any of those chemical structures, but you do need to know that in the middle, like on page 16, in the middle there is a intermediate carbon chain, is what it's called. Test question. And on either side of that, it's either an amino or an aromatic, which means that it's either lipophilic or hydrophilic, which means it is protein filled or water. It has to do with hydro, water. So the largest part of a molecule, the largest portion is the lipophilic part. It's aromatic in structure, and it's what helps the local anesthetic to diffuse through, is that lipophilic part. The hydrophilic part is amino, and it renders a molecule soluble in water. So the hydrophilic part is important because that's the way that it's going to be able to dissolve. The local anesthetic is in water. And the thing that is in between these two lipophilic and hydrophilic parts is what's called an intermediate hydrocarbon chain. And the intermediate hydrocarbon chain is what contains ester or amide linkages. So the test question will be, what determines whether something is ester or amide? It's the intermediate hydrocarbon chain. Okay, so that's what's going to determine that. And after that, there's really not a lot asked about those.
I have a question.
Mm-hmm.
What on our study guide, it states, what is the difference between secondary and tertiary amines? It's question 23.
Okay, so I have a different question. You name the secondary. And what's the question say?
It says, state the difference between the secondary and tertiary amines.
I don't know what I was after. Let me get back to you on that.
Okay, thank you.
I don't know what I was. Okay. So ester linked local anesthetic molecules, those that are ester linked are like procaine, are readily dissolved or hydrolyzed, broken down in a water molecule. In water. So a water molecule is added to a substance by picking up a hydrogen molecule in an aqueous solution. So that is exactly what happens when the only thing between, when you deposit a local anesthetic, it's going to have RNs and RNH positives, charged and uncharged ions of the local anesthetic. The only ones that can go through those sodium channels or get into the nerves are the base, the uncharged, the RN. So the RN positives are going to stay on the outside and just whatever. But the RN negatives are the base form. The RN, the base form is the only thing that can diffuse. But when it gets inside of the nerve, there's positive hydrogens floating around everywhere. And it's like a magnet. That RN then will go with the H positives, hydrogen positives molecules, and now they're RNH positive on the inside. So they can't get through on their own, but the base can get through, attach itself to a hydrogen molecule, and now it's charged again. So now we have RNH positive. RNH positive, that's what the only thing that can go up into the receptor sites, into the channel and block it. So no more sodiums can come through. That's what's blocking. Does that make sense?
So when the sodiums can't come through, is that how they can't feel anything?
Yes.
Okay.
So esters are no longer in dental cartridges. They had ester linked local anesthetics like procaine. They're no longer in dental cartridges. We only use them as topicals. They may still be parts of them in that hospitals use, but they always have like a bottle where they take some out. Dental cartridges are not like that. Dental cartridges are already pre-made in their cartridge. Okay, so they don't make any of that, but only as topicals. Like ester linked local anesthetic is benzocaine. Okay, it's only made as a topical. So you need to know that esters are biotransformed in the blood. Biotransformed means the same as hydrolyzed, means the same as broken down, or biotransformed. It's all for our purposes. There are technically some differences, but for our purposes, we need to know that all those words mean it's breaking down somewhere. And esters break down in the blood. If it's an amide linked local anesthetic, it's going to break down in the liver. So there's a greater percentage of the amide local anesthetic, which is unchanged in the urine. It doesn't really biotransform anywhere. It just releases out of the body, just unchanged, and in the urine. But that part that is changed is broken down in the liver. So it's EB. They may say just plasma or blood plasma or blood. Any one of those would be correct, where esters break down. Amides break down in the liver, so I say AL. So this is how I remembered all of the anesthetics, because prior, like I said, prior students have had to write down the anesthetics, and this is how they remember the ones that we have. You have esters or you have amides. These are the local anesthetics that are mostly used in dentistry, which have the asterisk. Okay, the mnemonic would be BLAMP. So BLAMP, that would be bupivacaine, lidocaine, articaine, mepivacaine, prilocaine. And we don't really, atitocaine isn't really sold. It's not easy to get in the United States anymore. So we add that, they add that on there. But I don't know anybody any questions that ever really come up with that. So I left it off. This HCl means it's a salt. It was made into a salt first, which we'll get into later.
And you said most of the amides are in your injections while the esters are in your topicals?
Yes. in
Okay.
dentistry.
Okay.
Like hospitals will still use procaine. Sometimes ENT use cocaine still to control bleeding. But for dentistry purposes, you would be correct. So this is what acid dissociation constant is. It's the acid dissociation constant is the strength of an acid in a solution. How strong is it? That's what acid dissociation means. And you could also say, have a question that would say, what is the measure of affinity of a molecule for hydrogen ions? It's just a big lot of words. How do you measure how well a molecule can pick up a hydrogen? What's that particular molecule? Is it like gonna, is it attracted like a magnet or slower, or what's the measure of how strong is the molecule for hydrogen ions, and how strong is the strength of the acid? So that's what acid dissociation constant means. So local anesthetics are generally weak bases, and you would need to know that. They're all weak bases to begin with. They're poorly soluble in water, and they're very unstable in air. And so they have to make them into, this is the raw first local anesthetic. So they have to do something to the form of that to make it usable, because it is not usable as a weak base, and all the local anesthetics start out as a weak base. It's not good if it can't dissolve into your system or your cheek or whatever, because there's water in your system and there's liquid, and so it's going to dissolve. And so if it can't dissolve to be able to diffuse through the membrane, what good is it? It's not. So they have to do things to that. So the pKa values of local anesthetics range from 7.7 to 9.3, because we really don't use the 3.51 that much. In this form, they have very little use, but when they're combined with acids, they form local anesthetic salts. And this is going to be a quiz question. I do see this in review books, that when local anesthetics are made they have and made into a local anesthetic salt. Now that salt can diffuse. Okay, now they're very soluble in water, and they're stable because it was first made into a salt. It's actually a hydrochloride salt. That's where they get the HCl. So when you see any kind of anesthetic, it could say 2% lidocaine HCl with epinephrine 1 in 100,000. But most of the time they just don't add the HCl part unless they're talking about an anesthetic that has no vasoconstrictor. It's just plain. Like 3% mepivacaine HCl, you'll see all the time. And that means it was made into a salt. It was an acid salt, because it can now diffuse into liquid, which can then, in the cartridge, which can then diffuse into your system. So every single acid salt has a different pKa. And some acid salts are actually bases. They'll be called an acid salt, but they consider it a base. So that's all you need to know about that, because some of the questions I've seen in review books will say all acid salts are, and it will say acids, bases, something else, and something else. And just your mind thinks if it's an acid salt, it has to be acid. And I want you to know that that's not necessarily true. An acid salt could be a base. So the answer would be acids and bases. Just wanted you to know that. So like you said before, the lower the pKa, the shorter the amount of time for the numbing action, or the faster. You could say it either way. is the onset of numbing action. The higher the pKa, the longer it takes for it to numb, or the slower it takes for it to numb. They phrase it in two different ways. So the pH is different because the pH means how acidic or basic is it. The pKa means what's the strength of the acid. The pH is how acidic or basic is it. So the actual nerve blocking action is determined by the pH in the local anesthetic and the pH of your tissue that it's going into. So inadequate anesthesia results when the local anesthetics are injected into inflamed or infected areas. And that's why that's a cardinal rule that we never ever inject into an inflamed or infected area, because number one, if you inject into there, it's already, anything that's inflamed or infected is highly acidic. So anything you put in there is going to sting even that much more. As acid more stings when you inject it in, the more acidic that it is. And so it also will cause much more bleeding, because local anesthetics are, first of all, they'll vasodilate those blood vessels, which will bring a bunch of blood flow into the area, and it will start bleeding a lot. So we never want to do that. We'll numb maybe that same tooth instead of infiltrating, which means to get that numb just at that one tooth in the infection part. We're going to go do a block, and we're going to give an injection back here because it's going to numb all three of those. And then we don't have to go into the infected part, but the tooth will be numb anyway. So it matters. So the pH of inflamed tissues is acidic. It's already a 5 to 6, and our normal pH tissue is 7.4. So the pH of solutions that don't have epinephrine in them, they're plain, is already going to be a 6.5. The pH of solutions with epinephrine, if it does have a vasoconstrictor epinephrine, is 3.5. So you're getting things that do have, even though we want to use epinephrine in our, if we at all can, that's always the better choice, is to use an anesthetic that has epinephrine for other reasons. But the downside of that is that it's probably going to sting more when it's going to be more acidic when it goes into the tissue until your body buffers it back to a normal 7.4.
So is it the pH value of a person's body that sort of causes the variety of how they react to the anesthetic?
Yeah, can be. Yeah, there's other things too, but yeah, first of all, it would be the pH. And if you already have inflamed tissues that are 5 to 6, we're not going to put something right into that inflamed tissue that's even going to be more acidic. So your actual local anesthetic without any vasoconstrictor, without epinephrine, is 6.5. So if our normal is 7.4, the actual plain anesthetic is already just a little acidic. And then we're going to put epinephrine with it, and that becomes really way more acidic. And it's because epinephrine is acidic, so it might really bring your tissue down to like the pH now, like to a 4.5. But epinephrine has to have a preservative. It's unstable in air. It doesn't have a long shelf life. It's all these things unless it has a preservative in it. The preservative is sodium sulfite, which we'll get to also. And that preservative also is acidic. So epinephrine is by itself, and if they decide to put a an antioxidant in it or a preservative, that's acidic. So now you have acidic going into acidic, and it will bring it down, the whole thing down to maybe a 3.5, which would sting a lot, a lot more. Now, also, all this stinging, the body has such a way that it's only lasting 3 to 5 seconds. It probably feels like 3 to 5 seconds, but the body is still going to, it's not unbearable. It's just saying that we're going to try as much as we can to stay away from inflamed areas, just to add to it's still going to sting. It's just, it won't sting as much if we stay away from infected areas, but also you don't want to do that for other reasons, which we'll get into later. Okay, so clinically, the lower the pH of a solution, the more burning sensation is felt, and the slower it slows the onset of anesthesia a little bit. So something with epinephrine, you may have to wait 3 to 5 minutes maybe instead of 2 to 4. Like if it was the plain, you may need to wait 3 to 5. And most of the time, from just experience, it never takes that long for them to become numb on the gums. It's just that you may not have really profound anesthesia until the 3 to 5 minute mark, but you may not need it. Then we're not going to be drilling a tooth like a dentist would. We're not drilling into the nerve. We're just on the outside, and that seems to be okay. So elevating the pH of a solution is the quicker the onset of anesthesia. But this I would know. I've seen this in many review books. It'll have a statement that says, when the pKa of a solution is the same number as the pH of your tissue, the most profound is produced. And the distribution of lipid and hydrophilic forms are equal. They're all equal. And if you take that chart in the book, look at the pKa numbers and look at the pH chart numbers, when those get to be, if they're both like 7.7 is a good number, and the closer that they are, the better, the more deeply that they will be anesthetized, the more profound it will be. And they'll still be anesthetized, but they could come out of it a little bit early when they're further apart than you want them to, maybe or maybe not. But if they are close, like one's a 7.5 and one's a 7.7, they're really close. And so they're going to have deep anesthesia. If they happen to be exactly the same, it's like you can't get any better than that. It's the most profound. And that you would just as a question, you never know when you're working on an actual patient what their pH is. We don't test for that. So in working with an actual patient, we don't know that this is or isn't going on. But it's important to know, just because it has to do with soaking it into our heads again about not injecting into inflamed areas, and to be, when you're choosing if you get a choice over lots of different anesthetics to use, that you try to use one that's kind of closer to the 7.4 pH of our body. But even if the numbers are both 7.7 and 7.7, whatever the numbers are, you would still have, even if it doesn't match the 7.4 of our pH, anytime those two numbers, whether that, like, let's say they're both 7.2, that would be the most profound anesthesia they could get. And that's all you need to know. So now we're going to go on the RNs and the RNHs, that part where I was explaining. This is the base form, the RN part, the anesthetic molecule is what we're talking about, and the positive charge, where this RN went inside and picked up an H positive. But on the outside of the nerve, the local anesthetic that comes out of our needle comes out with RNs and RNHs to begin with. So only the base form, the RN of the anesthetic, can diffuse across the nerve membrane. The RNH positives stay on the outside. And I guess there's a picture on, see, that part is not That's not accurate, that picture. And it doesn't really show. I don't like the ones that this one shows, so never mind that page. Anyway, once it diffuses and it doesn't penetrate, that's a big question too. What penetrates and what diffuses? If the test questions all talk about penetrating, they're meaning a needle, penetrating the skin. So the local anesthetic doesn't penetrate through a nerve, it diffuses through the nerve. It's soaked in, so you need to have those differentiations. So once diffused, the RNs, into the cytoplasm or axoplasm, which is on the inside of a nerve, the base, of course, is uncharged, and it's lipid, it's soluble, and it is a magnet. It picks up a hydrogen molecule, which is an H positive. And now on the inside, we're back to a charged molecule, an RNH. It just couldn't get in as an RNH. But now it's charged, and it's called a cation. It's not, it looks like cation, but that's not right. It's in science, it's called a cation because they're ions and molecules. So the RNH molecule is the only thing that can block the inside of the sodium channel by binding to the receptor site. They're waiting for it. So no more sodiums can come through those channels, and therefore the sodiums going through those channels are what's going to keep the pain coming. So once those sodiums are with the anesthetic, once those are blocked, when we go down, we block it, and then we're going to take a scalar down into their pocket really far down, and we try to pull it up, and a lot of blood is coming up, and which would normally be painful for them. Well, now that's blocked by our anesthetic. So when the stimulation of pain comes from the teeth to the anesthesia, it is coming. This is painful. And so the action potential is coming. It's going to depolarize and drop all those sodiums because it's a lot painful through, and it can't because we've now blocked it with the anesthetic molecules. Therefore, it's blocked completely, and until it wears away, or the anesthetic wears away and are no longer blocked, then no sodiums can come inside the axoplasm or whatever, and the brain stimulus is stopped. I mean, not the brain, the pain stimulus is stopped, and it cannot go further down a sensory neuron to the spinal cord or brain. Does that make sense?
Yes.
Okay. Well, we are now are we at 11:30? So, I mean, the rest of this I have already, I mean, I don't mind going on. You guys might mind. I don't know your schedule. You want me to go on?
Is Beckerly gonna jump on here?
Yeah, she can. You want her to jump on right now?
Well, I didn't know. She said 11:30, so I didn't know if she was going to.
Yeah.
I'm
You want her to jump on first? Let's listen
here.
to her, and then we can.
Can anybody hear me?
Yeah.
I'm on.
Oh,
Yeah.
good. I was just letting you know to get on.
Hey, you just text me. Let me mute that.
Okay.
Hello. Do you want us sharing your screen, Jeannie, or you want this to stay on the recording? And
No. All right. Let me stop the recording.